This is the Parkinson Network of Mount Diablo. And today we have Mary Cochran Abraham doing the presentation on dementia caregiving. The way we do these lunch and learns is the first 40 minutes or so is the presentation, and the last 15 to 20 minutes is questions and answers.
Great. Well, hello, everyone. My name is Mary Cochran Abraham, and I am a nurse practitioner at the Kaiser Memory Center. In addition, I happen to work at Kaiser Walnut Creek Neurology with our Parkinson disease patients. So I kind of wear two hats. And today's presentation, I'm going to try to share my screen. So today's presentation is about Parkinson disease dementia caregiving specifically. So the talk is pretty much aimed at people who are helping somebody with Parkinson disease, but those with Parkinson disease can also get quite a lot out of this talk. So first of all, what is dementia? We hear a lot about it. Some of us know quite a bit about it, and some of us might not. But dementia is actually just an umbrella term. A lot of people ask me, what's the difference between dementia and Alzheimer's? Dementia is an umbrella term. There are over 100 different causes for dementia. But dementia just means that there is a decline in memory or other thinking skills that is significant enough to interfere with daily function, and that's affecting more than one realm of thinking. Generally, dementia gradually worsens over time. At the bottom here, I have a list of what are these realms of thinking. It's kind of what does the brain do for us? It does a lot more than remember things. And so I have a list here of how it helps us with our speech and language, with knowing where we are in space and where everything else is, how to make calculations, how to make decisions, how to plan and problem solve. These are all things that the brain does for us. So as I said, dementia is an umbrella term. I have over here a short list of some of the causes for dementia. And as many of you may know, Alzheimer's is the most common cause. It accounts for over 50% of all dementia. And then we have vascular dementia, which is caused by strokes and by small microvessels in the brain being blocked. And then we have dementia with Lewy body and Parkinson disease dementia. Those two are actually related. And they account for a very, very small amount of dementia when looking at all the dementia that exists. And so the characteristics of Parkinson's disease. So Parkinson's disease differs from Alzheimer's disease. Parkinson's disease dementia, which I will abbreviate PDD in some of these slides, so that'll stand for Parkinson's disease dementia. So it involves a protein in the brain called alpha-synuclein, which many of you may be familiar with. This is the protein that kind of mucks up the works and causes Parkinson's disease. Its effects in the brain cause the motor problems that we see. Well, it turns out that it also aggregates into something called Lewy bodies, and that is what will interfere with cognition in people with Parkinson's. In Alzheimer's dementia, the protein that's involved is actually beta amyloid, so it's a different process in Parkinson's. I mean, in Alzheimer's. Now, the two diseases look different. Parkinson's disease dementia looks different than some of the others, meaning that people present differently. So there is less memory problems in people with Parkinson's disease dementia, at least in the beginning. And that's much different than Alzheimer's, where the predominant symptom is memory problems. So not so in Parkinson's. What we see with people in Parkinson's disease dementia, they'll have more problems with visual spatial functioning. So that would be recognizing faces is a visual spatial function. Knowing where things are, kind of having that map in your brain about where things are in the kitchen, recognizing things. You know, you'll say, honey, can you get the orange juice out of the fridge? And they cannot see it. It's sitting right in front of them, this big bottle of orange juice, and they might not somehow pick up on that that's the orange juice. So it's a visual spatial deficit. Other visual spatial functions that are affected, things like judging distances. This can be a problem when you go to sit down and you aren't sure how close you are to a chair, or when you go to step on a curb and you're not sure how far you are from that. That can be impaired. Also, the area of executive functioning is more affected, possibly earlier in Parkinson's disease dementia. That's the part of the brain that's doing those kind of higher functions, planning, problem solving, that kind of thing, making good judgments, good decisions. One example would be, you know, figuring out in a traffic jam, figuring out how to get around it, which would involve some planning as well as possibly visual spatial functioning. So with Parkinson's disease dementia, we see this more affected initially, and memory might not be so affected in the beginning. We also see people with kind of slowed mental processing. And you might think of it as, you know, in Parkinson's, movement can be really slowed, and the mental processing also is slowed. So you might ask somebody a question and it takes them a really long time to answer it. They come up with the answer, but it just seems like the gears are turning really slowly. So that's a little bit about how Parkinson's disease looks. What are its characteristics and how does it differ from Alzheimer's disease? So Parkinson's disease, dementia, is actually very prevalent among people with Parkinson's. So at any given point in time, some studies estimate that 25 to 30% of the people alive with Parkinson's have Parkinson's disease dementia. And so that's quite a high number. And other studies estimate that 80% of people with Parkinson's disease will eventually develop dementia at some degree. So it's very, very prevalent among those who have Parkinson's, unfortunately. So the average time between diagnosis of Parkinson's and development of dementia is 10 years, but there is a huge range, and it depends, you know, at what point in the disease did we actually recognize that somebody had Parkinson's and make a diagnosis. So that number varies quite a bit. Now, in terms of how much of all dementia is due to Parkinson's disease, maybe 3 to 4%. So as I mentioned, it's a much more rare form of dementia than Alzheimer's, vascular disease. Those are the two most prominent dementias, the ones that account for most dementia. Alzheimer's and vascular disease combined probably account for at least 80% of all dementia. So the risk factors for developing Parkinson's disease dementia when you have Parkinson's disease, of course, the older that you are at the time that Parkinson's disease was diagnosed, the greater the risk that you may develop the dementia. Or the longer you've had Parkinson's disease, the greater the chance that you're going to develop a dementia. If you have really severe motor symptoms, especially what we call the akinetic rigid type of Parkinson's, which is the Parkinson's where it's there's a lot of rigidity, movement is slower, there's not as much tremor. Those symptoms are going to lead to a greater risk for developing dementia. And then some of the other symptoms of Parkinson's disease that might lead to a higher risk of dementia. So the REM sleep behavior disorder that a lot of people have, where you act out your dreams in your sleep, is an increased risk for dementia. A decreased sense of smell. Some people with Parkinson's have a really significantly decreased sense of smell. Some people have low blood pressure, the autonomic symptoms, and these indicate a higher risk for developing dementia. And then visual hallucinations are really common in Parkinson's, and those folks who have visual hallucinations might be at a little more risk of developing dementia. The hallucinations are kind of a hallmark of Lewy body, which is another related disorder. So they're very common, visual hallucinations. And we'll talk a little bit more about that in a few slides. So what can we do about it? And the problem is that dementia affects a huge percentage of us. And we're talking just in general now, not Parkinson's disease, but dementia of all types affects probably 50% of all of us 80 and over. So age is the greatest risk factor for developing any type of dementia. And we do not have great medication. So there is no cure for this, just like there is no cure for Parkinson's. There's no cure for the dementia. We do have some medications that can help. And I list those medications here: donepezil, rivastigmine, galantamine, memantine. Donepezil is Aricept. You may know it by that name. Memantine is Namenda. Rivastigmine is Exelon, is another name for that. Galantamine, I usually just call it galantamine. That's what we call that one. These medications typically help about 30% of people with Alzheimer's, vascular dementia, and maybe even a little bit more Parkinson's disease dementia. People with Parkinson's disease dementia respond to the medicine sometimes a little bit better than other dementias. And they can help with the processing speed. They can help with memory. You might see people their memory might get a little bit better. They might seem a little bit brighter. Their word finding, if they have any difficulty with language, might improve. Their attention, ability to pay attention may improve. We don't see any improvement in the visual spatial functioning with the medications. And I want to emphasize that the effect of the medicine is subtle. So it is not like you take this medicine and your memory and brain is 20 years old again, because if that were the case, I would be taking it now and everybody else would be taking it. But unfortunately, that's not the case. These medicines may also help some folks with the hallucinations that they have. So that's a little bit about the medicine, which is a grim picture. We don't have great treatment. And I would mention that it makes the field very ripe for people who want to sell you something. There are a lot of things that we see marketed on television that are going to help you with your brain, help you with dementia. People ask me about Prevagen several times a week, and I always tell them, that Prevagen is really great at making that company rich. It does not treat dementia. And there's a lot of things like that because it's a horrible, devastating disease for which we don't have great treatment. So, and some of the hardest parts to deal with of dementia for caregivers are the neuropsychiatric behaviors. And that's the increased confusion, people. These are some of the neuropsychiatric behaviors that we see. People are more confused, and they might get really agitated and scared. They might be withdrawing from their normal social activities. Definitely people are more frustrated because the world is not, the way that they think it should be. Their perceptions are changed. And so it's a very scary place. The world with dementia is a very scary place. It's like things don't make sense anymore. People, when they get scared, a lot of people will get mad. So we see a lot of anger and frustration, and then people can become combative if they're very frightened. People who are scared usually respond with either flight or fright, or fight, flight or fight. So people will sometimes become really combative if they are scared. Some people will be wandering, they want to go home, even though they're at home. They might ask to go home. And then there's the hallucinations, delusions, and paranoia. And the hallucinations, as I mentioned, very common in Parkinson's disease, even without dementia, and certainly with dementia. Typical hallucinations for people with Parkinson's, they often see people or animals. And sometimes these are small people and animals. I had a patient, a lady who one night prepared dinner for the 9 little people that had visited her. So it's often these small people that we see with Parkinson's disease dementia. But these are the parts of dementia that make it very difficult for caregiving. And so educating caregivers is a cornerstone of taking care of people with dementia, so that they understand how to approach people and how to communicate with people who have dementia. And so basically very important to approach from the front so that somebody sees you and make sure they know who you are. So you want to make sure you call out, "Hi, Mom, it's Mary." And you want to come in and be on their level. And you want to pay attention to your own facial expressions, your body language, because if you are frustrated because your loved one has been asking you the same question over and over, can cause a lot of frustration. You can transmit that to a person with dementia, and they may become more agitated. So you want to make sure as a caregiver that you have a pleasant facial expression and that you are just generally cheerful. And then very important, you want to avoid arguing with people. That's the golden rule. Never argue. People with dementia cannot reason and think logically. So you need to adjust the way you communicate. And so you want to respect their perspective. For example, if somebody insists that there were people here earlier tonight, where did they go? All those people that were here, where are they? You don't want to say, "Oh, there were no people here. What are you talking about?" "Yes, there were people." "No, there weren't people." You get into the back and forth and a lot of resistance, and people get more agitated. So you don't want to go there. You make sure that you respect their perspective by, "Oh, there were people? I didn't know that. Well, you should have introduced me to them." You go with their flow. You don't go against their flow, because that causes the problems. That causes a lot of the agitation that we see. So you want to focus on their feelings. So, somebody's taken my wallet. I can't find it. I know that neighbor Joe has taken it. We hear this a lot in people with dementia. They have a lot of thoughts that are not real. Their brain is trying to make sense of the world. So what you want to do is not argue. Nobody took he wouldn't take that. I'm sure he didn't take that. That will get you into trouble. You would just say, "Oh, no, I'm sorry to hear that. Let's let's go look for it, or I'm going to go talk to him. The basic algorithm is you focus on their feelings, you respond to the feeling, you reassure them that you're going to take care of it, and you redirect attention to something else. When people are agitated, that's what generally works. It's like being an improv actor. You don't say no. So dad wants to go out for a walk. It's midnight, dark, cold, and he has no sense of time. Your initial reaction is to run up. No, dad, no, you can't go out now. Yes, I can. I want to go for a walk. You start with that. So if you always say yes, yes, dad, yes, I see you want to go for a walk. We are going to do that first thing in the morning. So you've redirected, you've validated the feeling that he wants to go. You haven't said no. You've just agreed, you've validated that feeling, and you redirect the attention. And that generally helps when people are starting to get agitated. And in basic communication, when verbal skills are declining, which is fairly late in the dementia process for Parkinson's, you want to use really short sentences, basic words, because people are not really taking in what you're hearing. Also, you want to speak slowly. You want to give a lot of time between what you say and waiting for a response to somebody because of that slowed processing speed. And it helps to put a gesture or a pantomime with your words, because the ability to understand language is possibly lagging or it's struggling. So for example, if you want someone to take a shower because they haven't showered in a long time, which is a problem in people with dementia, you want to use short sentence and put a gesture. I'm going to help you wash up. And you might motion like you're washing under your arms. You've put a gesture. So you don't go into a long explanation. You know, you haven't taken a shower for so long. It's time to shower. I've got this going and blah, blah, blah. They're not hearing that. So you want to make it really short. And it's best to have their attention. So if it's a family event or a gathering with several people, it'll help to make sure there's one person talking at a time to that person with dementia so that they can understand what you're saying. And you don't want to quiz people. Oh, see that lady over there? Do you remember her? Because, a lot of people want to see, where is Uncle Joe at in this dementia process? So quizzing is very bad for people with dementia. You're highlighting one of their deficits. So you want to put an answer into your question. Oh, see that lady? That's your favorite cousin Sue. Let's go say hi. You've put that answer in there. Or if you are at a restaurant making a decision about what to eat from a menu, it's to be very difficult when your brain isn't working right. So you can help by narrowing that selection. Oh, you know what? I've heard the lasagna is really great here. What are you going to have? That can help that person make a decision. They won't be overwhelmed with this huge number of choices, because making decisions like that is more difficult with dementia. So you want to narrow down the choices and put kind of the answers into your questions. So a little bit about hallucinations, because it's a prominent issue, especially with Parkinson disease dementia. So number one, if the hallucination is not disturbing to the person, then I am not going to worry about it. I'm certainly not going to need to treat that hallucination. The medications used to treat hallucinations have a lot of side effects. We use them only when hallucinations are very, very disturbing to the person with the hallucination. A lot of times it's the family members who are more disturbed. Oh my gosh, mom is seeing things now. and it can be very disturbing for the family. But if mom opens the window and sees 31 cats sitting in the tree outside, we do not need to set her straight on that. It's fine. Oh, wow, mom, 31 cats. What kind do you see? There's no reason to start telling her it's not true, because that will just lead to a lot of agitation and fear, So sometimes, especially with Parkinson's, people have a lot of misperceptions, which are similar to hallucinations, but a little different. So it helps to have people point to where they see something. Because if they're like, you see that man right there in the corner, and you look and there is a coat hanging on the back of the door, you might just turn on the light, and that hallucination might evaporate. So look for things that are in the environment that might be misconstrued as something else. So turning on a light, having them point to what they see, or taking their attention away from there, moving to another room, sometimes will help relieve a discomfort due to a hallucination. And so this slide is kind of just an algorithm about how to respond to a hallucination when somebody's really upset about it. You want to approach them from their dominant side. If they're right-handed, you would approach from their right side. And you want to take their hand in a hold called hand underhand that I wanted to talk about in the next slide. And you just want to be comforting. You want to repeat what they said. See that little boy right there up under there? Somebody get him out of there. That's not safe. So you approach from their right side. If they're right-handed, you take their hand. Oh, you see that little boy under there? You're right. They are not safe. You can kind of steer them away. I'm going to have somebody take care of that right now. And you kind of maybe walk over to a different part of the room or leave the room. This can help kind of alleviate that. And so the hand under hand technique is a very simple but powerful technique for helping people with dementia. And basically you reach out, you shake hands, and then you swing up and turn your hands over your kind of thumb to thumb in this hand hold right here. This is hand under hand. It puts a lot of pressure in their palm, which is very comforting to humans. And you can use it to help people with brushing teeth if they're not able to, using a washcloth, eating. It's a very powerful technique. And I have a video. I wanted to see if I could show you this video of hand under hand, because it's a lot easier to see this by video than it is otherwise. Let me see if I can do this. Not sure I can. No.
Can you click on the link and see if that does it?
Yeah, I had it up. Let me just, I think I have to go here. Here, I've got it. In this video, she's going to show us hand under hand in a stepwise way, so we'll be able to see that.
I'm going to get on the, are you right-handed? I need to be on the dominant side of the individual because that's where they have motor memory for doing all kinds of tasks. They don't know how to use their other hand nearly as well. So what I'm going to do is I'm going to get on this side. Now, hold hands like you normally hold hands. Shake hands like you normally shake hands. Go ahead and shake somebody's hand. And realize there's nothing real comfortable about that. I mean, once you shake hands, then it's like, okay, let go. And what we can end up with is a tug of war. Or late in the disease, people with dementia often like a lot of contact, and they'll squeeze you and actually hurt you. And it's like, ow, 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 ow. And where are you going to grab to get them loose? On the wrist. And what you're going to do is bruise them again. Shake hands, but then immediately slide up around so that what you're doing is holding on palm to palm, thumb to thumb, and you've got a lot of palm contact. Try that with your partner. And then turn it so their hand is on top of yours, and just relax the hand so that it's very clear it's relaxed. What you're doing is you're putting pressure in the palm, and pressure in a human being's palm calms them down. So what you're actually doing is helping to calm them, even while we're doing things, because I'm giving them input into the sensory system, okay? The other thing that I can do is take the other hand and lay it on top of the hand. And what I'm creating is artificial warmth and padding.
Okay, so that is hand under hand, and that's how to get into a hand under hand. I recommend practicing that with somebody so that you can get the idea. And once you do it a few times, it's pretty easy to do that. And then I wanted to show, can you guys see this, an excerpt of dental care for people with dementia? Are you guys seeing that or not?
Yes.
Okay. Because this shows how to use hand under hand to actually help people with a task.
So here's a note, the right hand or left hand? Right hand. Okay, so turn this way a little bit so everybody's gonna be able to see it. Now, before I had to do hand under hand, right? Now what you're gonna learn how to do is be the fine motor when they're losing it. The tool manipulation. So the reason I want her hand is her brain remembers her hand coming to her mouth. The reason I need my hand is she doesn't know how to manipulate a toothbrush anymore. So what I'm going to do is do the toothbrush. She is with me, and by being over here to the side, guess what? She literally thinks what? She's brushing her own teeth. Notice that I have my hand on her shoulder applying downward pressure. I'm tricking her mouth into not paying as much attention. Now you notice, it's a little bit tender around here. She's not real fond of this, but let me take away the hand and watch what happens. Much more intense because I'm actually tricking her brain. This is close and it's proximal, and so I'm actually tricking her brain into paying attention to the pressure on her shoulder. Now watch this. So does it make a difference?
Yes, it makes a big difference. This is a really important way to help people who have dementia and are losing these abilities. Because when you come at somebody with a toothbrush, just standing in front of them, coming at them with a toothbrush, or coming at them to unbutton a shirt to help them change clothes or whatever, it's very, very disturbing and it's distracting. Hand under hand puts you at their side and they are doing it with you. You've got their hand and their hand is doing whatever the task is that you want to do. So hand under hand, very, very powerful technique. I don't know if we have time. I had another video how to help somebody sitting down when they're struggling with that, but I think
Yeah, I mean, if you want, we have yeah, definitely. You have enough time to do another short one like the previous ones.
Okay, so let me leave this and the helping someone sit is really helpful, especially with Parkinson's, when people get that stiffness, and sitting down can be more of a challenge. So are you guys seeing this?
To help someone sit down when they're
No.
not sure how to sit down.
Okay.
You spread your.
We just see the PowerPoint.
Okay.
There's a video.
Okay.
Legs wide, so you get a wide base of support. You're gonna bend your knees, not your back. I'm gonna come in, I'm gonna help Marianne lean forward, and then I'm gonna touch her on the tendon while I support her back. So she controls the sitting and she doesn't lose her balance. So if Marianne stand, if I tip her back at all, she starts to worry that I'm going to knock her off balance. So when someone has a hard time, lean them forward, way forward, further than you think, but you have your arm and your elbow to support if they start to lose their balance. Forward. Now touch at the tendon that's on the outside of the knee, keeping them forward, and ease them down.
Okay, and that's really helpful with that difficulty of sitting that might happen with the stiffness people have in Parkinson's disease. And then with dementia, people will start to lose their ability even to kind of figure out how to sit down on their own. So, and that's of course much later in the disease process. So those are three useful videos. I've included links to those in the material that you should get afterward. Now, are you back to seeing my slides?
Yes.
Okay, good. So there's links here to the toothbrushing video and the how to help somebody sit. And I don't know if I sent you the other one, Rick, but I'll send the other one that just shows how to get into hand underhand. That tapping the tendon that she does when she's helping someone sit kind of is really useful. That kind of helps relieve that stiffness and helps somebody sit. So those are just some hands-on techniques for later in the course of the disease. So I just want to mention caregiving stress. Caregiving stress for anybody caregiving for any type of dementias is severe. It's very difficult. So I tell my patient family members, you know, you can't do this alone. It is a long journey. It's a 24/7 job. So you need support groups where you can talk with other caregivers going through the same thing can be really helpful. And I have here checkalz.org. That's the Alzheimer's Association website. And they have support groups that are all available now online. And so I want you to check that out. You can enlist other family members or friends. Caregivers need a break. You cannot do this 24/7 day after day. So enlisting help, or even if needed, you can hire help in the home. There are places called adult day centers that the Alzheimer's Association has the most up-to-date list for adult day centers, which are places for people with dementia. And they have activities, they have caregivers there, and people can go for a day. You can even arrange that a person goes twice a week or 3 times a week to spend some time in the adult day center, giving you a break. And then just to keep in mind that people will often get to the point where we just can't provide this care at home. And in that case, assisted living facilities can be very helpful, and they can actually allow you to enjoy your loved one more, because the heavy lifting, the hands-on caregiving is being done by somebody else, so that when you visit, it's just purely to connect with the person. So I have resources here for caregivers, and I've already given these to Rick. I have a compassionate communication tip sheet that reviews some of those communication tips. Here's the online classes and support groups from the Alzheimer's Association. And then the Parkinson's Foundation has some information about dealing with dementia as well on their website. So that's it for the presentation. It's kind of just the tip of the iceberg. So now, are there any questions? I'm going to stop sharing my screen.
All right, So let's see if we can bear with me for a minute while I unmute everyone. All right, when you have a question, simply unmute yourself. Mary, you'll have to unmute yourself. Great. All right. So if you have a question, simply ask it. This is the free form part of today's presentation.
I have a question.
Go ahead.
Mary, thank you very much for your presentation. What is the difference between memory care, assisted living, and just plain nursing home or assisted living? I'm not clear about that.
Okay, yeah, good question. So assisted living facilities have lots of different levels of care, and they don't all have all levels. So there's basically 3 levels in the assisted living facilities. There's independent living where you just have a common dining room, meals are provided, and usually they do some housekeeping of your own apartment. Then assisted living, there's more assistance that can be added to that. For example, medication management can be added in the assisted living section. Also, if people need help dressing or bathing, those type of activities, those can be done in the assisted living area. If people have dementia and they're more advanced in the disease and they would not be able to navigate to the dining room and back to their room, then there's the memory center or the memory area of the assisted living facility where there's more caregivers per resident, and there are activities that are specifically geared for people with dementia, more so than in the general assisted area. In the assisted area, people may or may not have dementia at all. They may need assistance. I know some of my Parkinson patients without dementia live in assisted facilities because they need help, getting dressed, getting showered, doing some of those things that they can't do because of motor problems. But the memory center is more geared towards people who actually have a dementia with those type of activities. And also they're usually secured, meaning residents cannot just walk out the door on their own. There's usually some mechanism where if somebody tries to leave without entering a code, the door would alarm in order to notify the staff to come and make sure somebody isn't wandering out, because that can become a problem for people with a memory problem, that they wander away, and that we don't want that to happen. I hope that answered your question.
Yeah, it helps quite a bit. Do they also have separate dining facilities for memory care versus?
Yes, so usually, my mom was in a memory care facility, so I got to spend quite a bit of time there, and people had their rooms in that particular facility. They had most of the people out in the common area. So they have common areas. Most facilities will have large common areas. They'll have a dining room. They'll usually have like a TV area with comfortable chairs. They'll often have a room for activities like crafts or other activities that they might do. And then they'll have, in that facility, the doors were locked unless a staff member went with you to your room, which I do not see in this area. That was up in Roseville. And it would be helpful if doors were locked, because there's a lot of problems that happen because people wander into someone else's room.
Yeah, I've heard that.
Yeah. And, it's like, why aren't you locking the door? I don't know if it's a regulation, but up in that particular facility, people were out in the common area. You don't want somebody with dementia alone in their room anyway. You want people out in the common area with the caregivers, so that they can make sure people are safe. And also you're isolated. If you are alone in a room with dementia and you aren't sure where you are and what's going on, much scarier than
Mhm.
being out with people.
Right.
So, and different facilities are different. And then there's also a place called a board and care that you may have heard of, which is licensed as an assisted living facility, but they generally are just homes in a neighborhood which are licensed for up to 6 people. And they will generally have 2 caregivers, 2 aides that are taking care of up to 6 people in a much smaller setting.
Thank you.
Mary, we have a question that's been chatted in from Scott. He asks, where do Kaiser members go to get evaluated for PDD and ask questions about medication?
Yeah. So within Kaiser, you would ask your primary care doc. You would let them know that you're concerned for memory problems or possible dementia. And then you can ask for a referral to our memory center at Martinez. That's in the Kaiser Diablo service area. If people are in Oakland, Berkeley, Richmond, that's not in the Kaiser Diablo service area. And those folks, we cannot really accommodate in the Martinez Memory Center. So those people would, in Oakland, Berkeley, Richmond, would ask primary care for referrals to neurology.
Mary, I was interested, have you experienced a lot of difference with the problems you talked about this morning since COVID's come along?
Oh yes, great question. So this whole shelter in place has just been very difficult for anybody struggling with a cognitive problem, basically for all of us, right? Whether we have a supposed cognitive problem or not, it has been hard on our ability to think. Like, you see people again, now that we're starting to maybe interact a little more, it's making it, difficult to speak. You haven't been used to speaking or carrying on a conversation. And all of that is brain exercise. Carrying on a conversation, causes you to need to follow along, to remember what's being said, to know what you want to say. It's a good brain exercise. And without that, with the shelter in place, people are set back. People have really been set back.
So what's Kaiser doing about it?
Yeah. So, yeah, what's Kaiser doing about it? Nothing. Nothing. Because really, there's not a whole lot Kaiser or Sutter or any of the health, providers can do. What I recommend to people is to talk with the people you live with, you can live with somebody and hardly say 2 words to them. We all know that if we're married. So making time to actually talk with somebody, going out of your way to have a conversation with the people you live with, or on the phone with people if you don't live with somebody, that's important to keep your brain working. So, but Kaiser can't really help with that in any real way. We do offer 2 classes for caregivers after a diagnosis in the memory center. And today, this class had a little bit of taste of that caregiver skills class that I teach there. But otherwise, we can't really rely on the medical providers to help with this issue. We really have to reach out on our own.
And a lot of the research has not been done yet because COVID is still pretty new.
Right. So you're talking about research about COVID?
Yeah.
Well, certainly, yeah, There's a lot of ongoing research about COVID, but the real impact that I'm seeing on people's thinking ability was more to do with the isolation caused by shelter in place. So the COVID disease itself has another impact, right? The disease itself can impact people's thinking.
Right.
People can get this kind of foggy brain thing that happens after you have COVID and you recover and you still have this brain fog. And that's a whole nother matter. That what is Kaiser doing about that? Nothing. Really, that's something that has to be researched, and it's kind of out of my realm of expertise because I don't treat COVID.
Can I ask another question?
Sure.
You mentioned that some people respond to medications with subtle changes. Do these subtle changes persist, or are they
Yeah, good question.
flash and then kind of taper off? Or
Yeah. So the subtle changes, the disease is progressing.
right?
It's still progressing even with the medicine. So here's an example of a pretty significant improvement. I had a lady who was a knitter, one of these ladies who was always knitting. She had stopped knitting because of dementia. With taking the medicine, she actually went back to knitting and was able to continue to do that for another year or two. It's kind of, the medicines kind of give you a bump up in your baseline, and then you still decline, but from a little bit higher spot. You can think of it that way.
So it's definitely worth trying then.
I think it's worth trying to see if you're one of the folks that responds, and people with with dementia due to Parkinson's respond a little better to the medicines.
Thank you.
And
I
you would
thought that was a
typically go to your
wonderful
neurologist for that?
Oh,
I'm sorry, go ahead, Derek.
No, I was just going to say, I thought the talk this morning was wonderful.
Oh, thank you. Good. Thank you. And then about the medicines, those are prescription medicines I'm talking about. So they could be prescribed by primary care. I certainly prescribe them in the memory center, and neurology also can prescribe them.
I have another question. After you've been seen at the memory center, how long does the follow-up persist? Is it voluntary, or does it happen automatically that you get reassessed?
Oh, the follow-up. Okay.
Yeah.
Follow-up in the memory center.
Yeah.
So generally when we see people and make a diagnosis of dementia, that person is part of our memory center indefinitely. And but once there's a diagnosis of dementia, it's already gotten to the point where they can't really make their own decisions. We don't see them again in the memory center. What we do is we are available for family members or people with the dementia, but usually I'm working with family members about any question or anything related to the dementia. You can always reach out to me, contact me. We offer our 2 classes for family members after a diagnosis. Now we follow up. If we see people in the memory center and there's some impairment, but it's mild, and we call this mild cognitive impairment, but they're still functioning pretty well. They can still make decisions on their own. We will see them back in the future because we will see them up until the point where clearly this is dementia and they're losing the ability for decisions. So the dementia is advancing. Once that's happening, we don't need to see them again. We know this gets worse over time.
Okay. Well, I'm
Question.
involved with the caregivers support group for PNMD. And so I'm wondering if I can say to the group that the Martinez Memory Center is available for the caregivers.
Yeah, so the caregivers,
if they have any questions or,
Yeah, the classes are actually available to people who've been seen in the memory center,
right,
not by other people.
right.
We're currently working out a way for neurology to send us folks who've already been diagnosed and whose family members need classes. But the thing is, there are lots of classes for free from Alzheimer's Association.
You don't need these, you don't need. I have a
All right,
question.
I have a question from
I have a question.
Mina.
Yeah,
Mina
hi.
Mehta.
Yeah, thank you so much. It was a wonderful talk. I have a
Oh,
question. We talk about dementia, but are there any, like, do you do any, like, are there any quantitative way? Can you like have a scale where, okay, 1, 2, 3, 4, 5, 6, things like stages of dementia and things like that? Do you do? And what are the best ways to stop progressing it? I mean, I could get part of it, but is there any way, like research happening where there's hope for people with dementia and for caregivers of
yeah.
people with dementia? But more, I was more interested in quantitative way to, and is
Yeah.
there, do you like study if somebody is exposed to different ways, like concussion and surgery and Parkinson? Is there a way to find out what was the reason for exact contribution, or once the person is diagnosed, you say, okay, that's it, you're done, you know?
Okay, so that's kind of, seemed to be a lot of questions in there.
Exactly. I'm sorry.
So one of them was about the stages of progression. I can give Rick a sheet about that. I have a
And we can then
sheet,
post it on the website.
yeah, to be posted later on the website about stages of progression. If you Google stages of progression, you'll see some information there. So that was one of your questions. And other than that, what was it was hard to say.
Like if somebody had, like, let's say somebody had concussion, then surgery, Parkinson, is there a way to figure out what exactly
No, there's not.
proportion?
Mm-mm.
There is no way, nobody does any research, that kind of
No,
thing.
well, research, yeah. So these things all cause dementia, right?
Right, exactly.
Concussion, people with traumatic brain injury can develop a dementia. Alzheimer's, people can have mixed pathology. So you can have multiple things going on in your brain, and that's
Correct.
actually common. People will have some Alzheimer's pathology as well as vascular pathology. And people with Parkinson disease dementia can have also some vascular going on, and maybe some Alzheimer's pathology can be present. And the only way to quantify that is on autopsy.
Okay, I want to get in where
Thank
at
you.
1 o'clock, if I could. I have somebody raising their hand, Abraham.
Oh,
Yes. Hi, hi, Mary.
hello.
Well, thanks for your presentation. Very informative. I have a question. If you come to a support group and it happens to be a Parkinson support group, what things would you see in the group which as an information, we are helping our members and each other?
I think what you're asking is about whether the memory center it's in Martinez is available to others, and can we refer our people to the Kaiser Martinez Memory Center? Is that it? And then we have to get ready to close.
Okay,
So
that's,
Mary,
thank you.
Yeah, so Kaiser doesn't run any support groups. Yeah, those are run through the Alzheimer's Association. And then, this is a support group right here. You guys are all involved with this, and it's really one of the best groups. I'm very impressed with this group, PNMP. Very impressed.
okay, folks. I'm sad to say that we're still in the throes of this, but we're nearing the very end of today's presentation. I'd like to let people know that two things. One is that this presentation has been recorded, and that will be up on via our website at our YouTube channel within a day or two. In addition, the PowerPoint and other resources that Mary referred to will be on our meetings page after another few days. So I would really like to thank Mary and all of you who stayed through. I know this has been really valuable. And let your friends know that they can watch it on the YouTube channel, which is, by the way, a good reason to subscribe to our channel. So whenever new videos are put up such as this, you can see them. And thank you very much, Mary.
Yes, thank you. Thank you for having me.
Thank you.
And thank you all.